afternoon to all. It gives me a great pleasure and honor to introduce Professor Avroy Fanaroff. Professor Fanaroff is a master neonatal physician and an exceptional educator. He's a pioneer and leader in the field of neonatology and has brought the subspecialty to the new subspecialty that we know and see before us from an anecdotal-based field that was characterized by benign neglect and disastrous interventions into a very scientific, sound, evidence-based branch of pediatrics and obstetrics. During his career to the application of newer therapies, he and colleagues reduced the borders of viability from 28 weeks to around 23 to 24 weeks. He's currently an emeritus professor of pediatrics at Case Western Reserve University School of Medicine in Cleveland, Ohio. He was born in Bloemfontein in May 1938. Educated at Yeovil Boys Primary School, then moved on to King Edward VII High School in Johannesburg, where he matriculated in 1954. He graduated from Wits Medical School in 1960. He had a house job. He did his house job at Johannesburg General Hospital and then commenced his pediatric training at Addington Hospital in Durban, followed by the Transvaal Memorial Hospital for Children. He chose pediatrics, believing that if a child was cured, their whole life was ahead of them. And neonatology, because as so little was known about it then, and the mortality for prem babies was so high, he felt he could make a difference. After training in South Africa, he went to London and trained and studied further at St. Mary's Hospital, Paddington, and the Middlesex Hospital in London. He became a member of the Royal College of Physicians in 1964, and subsequently a fellow of the Royal College of Pediatrics and Child Health in 1998. He moved to Cleveland, Ohio in 1969 to take up a fellowship in neonatal perinatal medicine under the tutelage of Dr. Marshall Klaus. Professor Fanaroff has authored and edited 3 leading textbooks in neonatology: The Care of the High-Risk Newborn, Neonatal and Perinatal Medicine with Martin, and Neonatology at a Glance, which includes his son as an author as well. He has been an author and written and co-written over 300 papers in peer-reviewed journals and served as an editor of the Yearbook of Neonatal Perinatal Medicine for 30 years. And he is a founding member of the Eunice Schreiber Kennedy National Institute of Child Health and Development Neonatal Research Network. Amongst his awards, he's been inducted in the Cleveland Magazine Medical Hall of Fame in 2003. In 2005, he received an honorary fellowship of the Royal College of Pediatricians and Child Health in London and was named a legend in neonatology in 2006. He received the Founders Award from the Midwest Society for Pediatric Research in 2009 and was named amongst the best doctors in his field annually from 1994 through to his retirement in 2012. He was recognized with 2 honorary MDs, one in 2004 from his old alma mater, which is Wits, that's us, and the other in 2006 from the University of Turku in Finland. Amongst his work, he worked tirelessly on extremely low birth weight infants with regard to the diagnosis, treatments, and outcomes of critically ill neonates. He focused on respiratory disorders and which included the first randomized trial of continuous positive pressure, airway pressure ventilation, and the development of the nasal prongs that would administer the CPAP and the prevention of oxygen toxicity. Amongst his other works, he looked at large or insensible water losses and published on the vulnerability of hospitalized neonates if their parents did not visit frequently. He was one of the first investigators to define the epidemiology of NEC and also helped to define the importance of fungal infections in infants as well as the clinical features of sepsis in very low birth weight infants. With his colleague, Maureen Hack, he systematically documented the changes in survival and short and long-term outcomes of very low birth weight infants and followed them to adulthood. Amongst his executive positions, he served a 6-year term on the board of University Hospitals Health System and was on the executive committee of the American Board of Pediatrics, as well as the chair of the Board of Neonatal Perinatal Medicine. He served on an advisory position to the chair of the executive for the American Academy of Pediatrics Neonatal Perinatal Executive Committee from 2000 to 2012, and was the chair of the Organization of Neonatal Training Program Directors. He served on an international task force to expand the screening for critical congenital cyanotic disease in Europe, and is currently the executive director of the International Neonatal Association. It's a great pleasure and honor to welcome you, Professor Fanaroff, and I'm sure you will share your vast experience as well as your many anecdotal stories that you have gathered along your journey. I welcome Professor Fanaroff. Thank you.
Thank you, Professor Nakwa. It's my pleasure to be here in Johannesburg and to participate in the alumni lecture series. I welcome all of those who are on this Zoom call, which includes alumni, colleagues, friends, and perhaps even some members of my family. It's hard to believe that it's over 60 years since I graduated from the University of Witwatersrand. Visiting back in Johannesburg is bringing back many pleasant memories. Okay. So this is a picture of Rainbow Babies and Children's Hospital. And at night, each floor is a different color. It's the colors of the rainbow. This hospital was built and completed in the early 1970s. Here's a picture of downtown Cleveland. When we arrived in Cleveland, it was the 7th largest city in the United States and was the 2nd largest auto manufacturer, but it was also known as the mistake on the lake because a lot of industry was starting to leave Cleveland. It was then referred to as the Rust Belt, and the final straw was when the river caught on fire. This is the old Johannesburg General Hospital where we trained as medical students. And I'd like to start by paying tribute to some of my mentors. At Children's Hospital, Sam Javits, Seymour Heyman, Solomon Levine, and at the General Hospital, Mosey Sisman, and in Cleveland, Marshall Klaus and John Kennel. They taught me not to be afraid to think outside the box. Marshall Klaus started his career as a respiratory physiologist, and he discovered the lipid component of the surfactant. He noticed that the mothers of babies who'd been on ventilator behaved peculiarly, and so he directed his attention to maternal-infant bonding, and that was how he finished his career. But he made a huge difference together with his colleague, John Kennel, and I'll say more about that in a short time. He made me more inquisitive and prompted me to ask key questions. This was the staff at Transvaal Memorial Hospital for Children in 1962. Seated in the center are Seymour Heyman and Sam Javits. Now, Sam Javits was a real genius because he basically was using an algorithm before the term algorithm had ever been coined. And what he would do is he would look at the two leading features and symptoms of the patient and say, well, for example, there are 20 causes of hepatomegaly, there's 6 causes of eosinophilia. They intersect at these points. If we do these tests, we'll get the answer. And most of the time, he was correct. I'd also like to recognize that we all depend on our colleagues and on the nursing staff, the respiratory physiologists, the physical therapists. This is a picture of the neonatal division when I took over as director in the early 1970s. And this is a collaborative group that includes from the Middle East, people from Lebanon, Jordan, Egypt, and Israel. From South America, we had people from Argentina. We had people from Australia, South Africans, India, and we all worked well together and for many years. And I just wish that the world would recognize that we can do a lot better in collaborating and working together. This is the initial NICH Neonatal Research Network group, and I did a lot of collaborative research with them and would like to pay tribute to them as well. Now, Pierre Boudin was the founder of modern neonatal medicine. He published his book in the late 1890s, and he stressed the importance of proper nutrition, prevention of infection, and keeping the mother nearby the baby. He promoted breastfeeding and substituted sterilized milk if natural nutrition failed. He popularized gavage feeding for the premature infant who was too weak to receive nourishment by conventional means. Now, my career in neonatology really started at Baragwanath Hospital under the tuition of Sam Wayburn. And Sam followed Boudin's principles. He kept the nursery warm. At Baragwanath, there was one or two potbelly stoves. There was no central heating, and the babies were all wrapped in cotton wool. The mothers were not discharged. They were forced to stay at the hospital, provide human milk, which was pooled and pasteurized. He emphasized hand scrubbing and health. And my first study with them was actually done on hypothermic neonates. These are babies with temperatures less than 90 degrees on admission to the hospital. This is Fahrenheit. We warmed them, and although the literature suggested they would become hypoglycemic with rapid warming, this in fact was not the case, and most of the babies actually survived. And the survival at Baragwanath Hospital in the early 1960s, without any advanced equipment, was as good as anywhere in the world. This is a picture taken around that time by Jeff Mazels, who's also a neonatologist, of mothers providing human milk, which was then pasteurized. The problem is we've gone through the golden era of neonatology, but we also made a lot of mistakes, and there were a lot of disasters. In the 1940s, Terry reported retinal detachment in premature infants who received oxygen over a prolonged period of time. And the poster child for this is Stevie Wonder. And the term at the time was retrolental fibroplasia. It's now referred to as retinopathy of prematurity. And the interesting thing is that oxygen is something that we use all the time. You would imagine after 200 years of using oxygen, we would know how to use it. But in some recent trials where low saturation, 85 to 89% target versus higher saturation, 91 to 95%, the mortality in the higher saturation group was higher. And we still see retinopathy. And in 2023, we still don't know what the optimal oxygen environment is to grow a baby. And we still see retinopathy of prematurity. However, the treatments for retinopathy have improved substantially. So if we look at the evolution of neonatal intensive care, there are three main eras that we could refer to. The hands-off years or era of benign neglect, which Dr. Nakwa referred to, which was like the 1920s to the 1950s. The heroic years where there were interventions with some disastrous outcomes. And then from the 1970s, we start seeing the experience years where evidence-based medicine starts to emerge. And what we're looking forward to is the next era of precision or personalized medicine. Because in evidence-based medicine, we know what happens to a group, but we don't know what happens to an individual. So we may know that 60% of the group are going to survive, but we can't pick out de novo which ones these are going to be. Whereas once we get to personalized medicine, the precision will be a lot better, and we will be able to predict outcomes and also to provide designer therapies for the patients. So why do I refer to the 1950s as the era of benign neglect and disastrous interventions? Well, there was a high mortality and high morbidity. There was the retinopathy produced by oxygen, and somebody published a study and said that ACTH administration will reduce retinopathy. In fact, it increased it. It was an era in which there was a restricted use of oxygen, and I'll come back in the next few slides to show you how detrimental that was. There were major efforts to prevent infection. And we're now talking about babies with a birth weight of 1.8 to 2 kilograms. And two of the trials that were done, the first with penicillin and sulfonamide, resulted in connectors. And the second was the use of chloramphenicol, which produced the gray baby syndrome and increased mortality. The Apgar War was described by Virginia Apgar, who's pictured on the slide. She was a very interesting lady. She described the Apgar score on a napkin in the cafeteria talking to some medical students. That's where she wrote it down for the first time. It was not very scientific, but it did help identify babies who needed assistance at birth. There were, on the positive side, Bill Silverman started the concepts of randomized trials in babies, and the randomized trials of thermal regulation showed that avoiding cold injury, keeping babies warm, was very important, and that there was some confusion about the role of humidity, but he sorted that out and showed that with increased humidity, you were actually increasing the temperature and keeping the babies warmer, which is why they did better. The 1950s, the concept of prolonged starvation, so that the smaller the baby, the longer you didn't give them any food. The result was hypoglycemia, dehydration, and of those who survived, the neurodevelopmental outcomes were horrible, with somewhere between 40 and 60% of them having poor outcomes. Failure to promote breastfeeding for preterm infants, it wasn't recognized how important the human milk was for the premature infant. Now, this is a graph which clearly shows that the mortality was falling in both the US and in the United Kingdom. And then we see it start to level off and actually going back up. And this was after retinopathy or retrolental fibroplasia was reported in the 1940s. And the goal then became to restrict the amount of oxygen. And the net effect was that mortality went up, and Kenneth Cross in England estimated that for every case of retinopathy, you prevented 16 babies were dying. So the oxygen story in the 1950s and 60s was not a pleasant story. The 1950s, no intensive care, and parents were not allowed in the unit, which resulted in abuse and abandonment. Dr. Noko referred to what was my first study as a neonatal fellow. We kept a book of visiting patterns by the parents and showed that the mothers who visited less than 3 times a week were more likely to abandon and abuse their babies. So Klaus and Kennel, pictured above the parents here, promoted family visiting throughout the hospital stay of their babies. And they really engineered the concept of family-centered care before the term family-centered care was ever used. And they were directly responsible for the movement that allowed the parents into the unit at any time and allowing parents into the delivery room as well. And I think by their actions, they saved a lot of abandonment and abuse of babies. This is the data from the chloramphenicol trial. And we see if you were not on antibiotics, the mortality was 19%. If you got chloramphenicol, the mortality was 60%. If you had pen and strep, it was 18%. But if you had penicillin plus strep plus chloramphenicol, it went back up into the high 60%. Babies are not able to metabolize the chloramphenicol in their liver. It accumulates and causes gray baby syndrome and death. The modern era of interventions in neonatal care really started in the late 1940s with Wallerstein doing an exchange transfusion, putting the blood, taking the blood out of the sagittal sinus and putting it in a superficial vein. Today, if you put a needle into the sagittal sinus, you can bet that you're going to be sued. Lou Diamond, who's pictured below, first introduced umbilical catheterization, and that heralded the modern era of neonatology. Intrauterine transfusions, which were done for RH disease, were promoted by Liley in New Zealand. And what he commented on was that as many areas of science, major advances result from what he called serendipity. But he said it's not luck which determines the major advances, but rather the presence of a disciplined, prepared mind that can recognize the observation, the significance of the observation, and continue to go ahead with intervention. And I'm not going to read all of this, but the bottom line is that during an amniocentesis, he punctured the belly of the baby and got out yellow liquid, recognizing that this was acidic fluid. And he said, well, if I can inadvertently puncture the abdomen, why can't I just do it deliberately and put blood into the abdomen? And it's been shown that if you put blood into the peritoneal cavity, it will be absorbed and the red cells will be valuable. And so this is how intrauterine transfusions were born. And together with intrauterine transfusions and exchange transfusions, the mortality was markedly reduced in Rh disease, and subsequently the development of ROGAM has virtually eliminated Rh disease as a problem. Now, in the early 60s, we weren't treating jaundice other than doing exchange transfusions. But a head nurse, a medical student in Birmingham, England, noticed that the babies on the sunny side of the nursery, and Birmingham, England is not the place where there's a lot of sunshine, but they noticed that they had less jaundice. So this resulted in the formation of phototherapy units and using white light, which contains blue and green, because the bilirubin is converted by the blue and green light into a soluble, water-soluble solution that can be excreted by the kidneys. And so lots of babies have avoided exchange transfusion with the use of phototherapy units. Today they use pure blue lights because it's very effective. Green is just as effective. However, the babies look terribly ill when they're under green lights, and the medical staff look even iller when they're around the green lights. So that's why the blue lights are used. Now, there was a major event in the early 1960s, and that was the birth and death shortly thereafter of Patrick Bouvier Kennedy, President Kennedy's son. Now, he was born at 34 weeks and he weighed 2,100 grams, and he had respiratory distress syndrome. At that time, we didn't have surfactant, we didn't use antenatal corticosteroids, we didn't have CPAP, we didn't have ventilators. And so they put him in hyperbaric oxygen, which was very damaging as the baby became severely hypothermic, and he died at 2 days of age. I would love to get my hands on the medical records because there have been all sorts of rumors about what really caused the death of this baby, including the fact that somebody may have punctured the heart in treating a pneumothorax, but until they unseal the records, we're not going to know for sure. There was one benefit from this tragedy, and that was the formation of the National Institute of Child Health and Disease, now known as the Shriver National Institute of Child Health and Disease. And through this agency, a lot of very productive research has taken place. And as a result, some outstanding therapies have been introduced, and the lives of many babies have been saved. Now, when I was a resident in the 60s, the major problems that I dealt with were asphyxia neonatorum. And when you were severely asphyxiated, you often became scleremic, your skin became thick and non-elastic at all. There was respiratory distress syndrome, and there was a lot of confusion, particularly in this country, as to whether Black babies got respiratory distress syndrome. They thought they had pneumonia. In fact, a lot of the babies with respiratory distress at Baragwanath Hospital were small for gestational age, so they weren't really premature. And they indeed did have pneumonia rather than respiratory distress syndrome. Subsequently, we now have CPAP, ventilators, surfactant, and antenatal corticosteroids, so that this is not the lethal disease it was. We took care of many infants of diabetic mothers. They were large for gestational age. They had birth trauma. They had hypoglycemia. They had polycythemia. There were more birth defects. As a result of better management of the diabetic mothers, these complications are much rarer today. I've already addressed the issue of Rh disease and jaundice. Meconium aspiration was very common, particularly in babies who were allowed to go past their birth date, post-mature, beyond 42 weeks. There were all sorts of birth defects. Today we can prevent at least neural tube defects with the use of folic acid. There were many infections, including neonatal tetanus, and the pioneering work on the treatment of neonatal tetanus was done in Cape Town, at the University of Cape Town. And it also showed the ability to ventilate newborn babies because they were using assisted ventilation for the treatment of neonatal tetanus, and that was very helpful. There was also prematurity and hypothermia. So what are the borders of viability? We read about them in the newspapers, about miracle babies. I think it's really interesting to look at the dawning of neonatology. In 1971, Schaefer, who coined the term neonatology, actually in 1960, wrote, "The lower limits of viability probably around 28 weeks, at which time infants weighed 2 pounds, 4 ounces, or 1 kilogram. During the past 50 years, the gestational age boundary has dropped considerably, and we're now caring for and seeing survival of much smaller and less mature babies. Excuse me. Today, the most immature infants cared for by neonatologists in some parts of the world are 22 to 23 weeks gestation. 25 years after the note from Schaefer, we see, and this is data from Maureen Hack, my late colleague, that the survival increases with increasing survival, gestational age, and going as low as 23 weeks, we were seeing survivors in 1996 to 2001. The most recent data from the NICHD network from Ed Bell, who was the head of the study, of 10,877 infants, 78% survived to discharge. It was 11% at 22 weeks gestation and 56% at 23 weeks gestation, and was 94% at 28 weeks gestation. So survival has improved. Now, what are some of the things that have contributed to the improved survival of these premature infants? Kangaroo care is one of them. This is skin-to-skin care of mothers with their babies or fathers with their babies. It's improved breastfeeding, it's improved milk production, and has produced improved parental bonding. Both parents can be encouraged to do it, and immediate kangaroo care was recently reported in the New England Journal of Medicine to improve the survival of infants of low birth weight. The concept before this trial came out was that you shouldn't do it on the very low birth weight because they were not going to tolerate it. But this study from Luddington and Bailey really proved that kangaroo care is important. The neonatal resuscitation program, the brainchild of a physician and a nurse, have now been in a worldwide program. There are millions certified. There's an evidence-based algorithm that drives the approach to everything in neonatal resuscitation. It's eliminated a lot of unnecessary interventions, for example, intubation of all meconium-stained babies. The good thing about intubating all meconium-stained babies was that the residents became very experienced at intubation. But it is traumatic, and the fact that it's not necessary is important that it's been noted in randomized trials. The LCOR is revised every 5 years. It's strictly evidence-based and is extraordinarily helpful. And this has been followed by Help Babies Breathe, which is a fundamental training for lots of babies in the world who are delivered at home. And there again, there've been increased survival and less morbidity by training lots and lots of individuals. Why did we clamp the cord within 6 seconds of delivery? Purely obstetric convenience. In the animal kingdom, they don't bite the cord after 6 seconds. They eat the placenta after all the blood is drained from the placenta into the baby. So in the last decade, there's been a lot of interest in whether delaying cord clamping or cord milking will improve the outcomes. And in this report from Fogarty, which includes 8 randomized controlled trials. Most infants allocated to the delayed clamping, which is 60 seconds plus, have done better, and the hospital mortality was reduced substantially. So this is a non-tech approach. It's very simple. Everybody can do it. It improves the outcome. Kangaroo care also, it only takes the parents. Elimination of early onset infections has had a major role in lowering mortality as well. We now have universal screening in the United States for Group B strep. If the mother is carrying Group B strep, intrapartum administration of antibiotics is very effective, as you can see in the white graph. Late onset sepsis is something that we accepted. We said these premature babies have a 20% risk of getting infection during their hospital stay. Not so fast. What if we put together a team and we take great care of the insertion of lines, and we take great care in the monitoring of the lines. We take great care of the hubs. We don't use the lines unless absolutely necessary. Well, it's a team concept. You have to get everybody to buy in, and this has been very effective. In fact, decreased sepsis, late onset sepsis, from 4.3 to 1.6 per 1,000 patient days. And in the unit today, we basically do not accept any rate of infection. It should be 0. And to encourage the staff, we put up signs that say, no infections for 5 days, no infections for 7 days, etc., etc. My biggest disappointment as a neonatologist was in the first trial that was carried out within ICHD Neonatal Research Network. 10 previous randomized trials, no larger than 100 babies, had shown that intravenous immunoglobulin given prophylactically reduced nosocomial infection. Well, 8 centers embarked on the trial. We enrolled over 2,400 babies in the trial, and the bottom line was that infection rate in the IVIG group was 17%, in the control group was 19%. There have been many studies since then. All of them have had the identical results. In other words, you can't use a generic intravenous immunoglobulin to prevent infection. You need a designer immunoglobulin. So at the interim, how much progress have we made? Well, more babies survive. More babies survive intact. But there are also going to be more babies with neurodevelopmental handicaps. The rate of nosocomial infection is reduced, and congenital malformations, not prematurity, has now become the leading cause of death in the United States. What are some of the other disasters that are referred to? Diethylstilbestrol. Millions of mothers were given diethylstilbestrol to prevent prematurity. It didn't do that. And what it did do, it's a teratogen and caused adenocarcinoma of the vagina, breast cancer, hypospadias, and affected second and third generations. Why was it used? Because people thought it would reduce prematurity. In the 60s, there was the thalidomide disaster, and I've said the power of one. And the reason I said the power of one, there was a lady on the FDA by the name of Frances Kelsey who said, I am not satisfied that this may not be harmful to the unborn child. In many parts of the world, thalidomide was used because it's a very effective antiemetic and was used for hyperemesis or emesis during pregnancy. Today, thalidomide is back in vogue as long as you're not pregnant, because it's used for the treatment of myeloma, and it's also used for the treatment of leprosy. But in the 60s, thousands of babies were born with limb defects as a result of maternal exposure to thalidomide. In the 1950s, Staphylococcus aureus was a common cause of infection, and particularly of the umbilicus. So if you've got an infection, you want to prevent it, right? Why don't we buy the babies in Pfizer hexachlorophene, which is a potent anti-staphylococcal cleansing agent. But if you're going to have to do that, if you're a premature baby, you're going to have it multiple times. So what they discovered is that babies who had been exposed to multiple doses of hexachlorophene had holes, vacuoles in the brain. There was one interesting study that I'd like to refer to, what I've referred to as a tragedy averted. And Marvin Kornblath, who wrote a brilliant book with Bob Schwartz on carbohydrate disorders in newborns. It was at his unit. And they were having trouble feeding these premature babies. And they said, why don't we do a feeding gastrostomy? The surgeons were gung-ho to do a feeding gastrostomy. And they did it as a sequential analysis. And in a sequential analysis, you only plot the untied pairs. So there were 31 pairs that were tied. In the untied pairs, we find that the survival was less in those with gastrostomy. We see it crosses the yellow line, showing that this is statistically significant. However, during the 14-month study period, the overall mortality dropped. So had this study not been done with controls, the conclusion would have been that we introduced gastrostomy and that's what's saving the lives. So the importance of the control group is re-emphasized in the study. And we try to practice safely. One of the areas that there's been growth of recently is the addition of simulation to training. And probably the most important part of simulation is the debriefing. And the team can then see what errors, if any, did they make. So hyaline membrane disease, or respiratory distress syndrome, as it is now called, was a major killer for premature babies. The most important study, besides the discovery of surfactant by Mary Ellen Avery, was this study done by Vincent Harrison at the University of Cape Town. And when babies have respiratory distress syndrome, they grunt. And the reason that they grunt is they breathe out against a partially closed glottis, which keeps air in the lung. So they studied grunting in 22 infants with hyaline membrane disease. And during expiration, the intrapleural pressure is increased by closure of the glottis and contraction of the abdominal muscles. They could stop the grunting by putting an endotracheal tube into the trachea. But when they did this, the arterial oxygen saturation fell. Now, you've got to realize that at that time, to measure the arterial oxygen saturation took 3 milliliters of blood. And if you were monitoring a baby of 750 grams, their total blood volume would be less than 80 ml. So if you did 4 samples of 3 ml each, you would have drained them the equivalent of 10% of their blood volume. So the ability to miniaturize and do blood gases on less than 0.3 of a milliliter and then on 2 capillary tubes was a major advance. As a result of Harrison's work on grunting and recognizing the importance of what it was, George Gregory, pictured on our right with the glasses and without the flowers, Bill Cooley on the left, published this article on the treatment of idiopathic respiratory distress syndrome with continuous positive airway pressure, the CPAP, in the New England Journal of Medicine. I want you to note that the babies were all big, 920 to 1,500 grams with the smallest lot. And there were 10 in that group, 5 in the next group, and 5 in the third group. If you submitted a paper to the New England Journal of Medicine today with a total of 20 babies, it'll come back faster than you can believe. It'll boomerang on you. Yet the editors in their wisdom published this, and this had a major impact across the United States because within months, everybody was doing CPAP. We did the first randomized controlled trial, but more importantly, my colleague, Marshall Klaas, had polio when he was a resident, and he had a flail right arm. And so it was not easy for him to intubate. So he looked for all different ways to avoid intubation. And with our fellow John Catwinkle and working with the biomedical engineers, in less than 6 weeks, we designed and produced the nasal CPAP units, which are seen throughout the world today and are used particularly in adults with sleep apnea. Now, you can do harm actively and you can also do harm passively. The story of antenatal steroids is harm done passively. In 1972, Liggins published a paper in Pediatrics showing that if you gave antenatal corticosteroids, the incidence of respiratory distress syndrome was 4.3% compared to 24% in the controls. In 1994, at a consensus conference on corticosteroids, only 19% of women delivering before 34 weeks gestation were receiving antenatal corticosteroids. The conference showed with a moving meta-analysis that the meta-analysis never actually moved, that the data that Liggins had shown came through 20 years later, and there was an overwhelming case for using antenatal corticosteroids. And so after that, it started being used liberally. And we can see in this graph from a paper by Wally Carlo, who is one of my fellows, that the use of antenatal corticosteroids was beneficial starting as early as 23 weeks gestation, where there was a 34% survival versus 13%, going up to 28 weeks, where you had 91% versus 89. So antenatal corticosteroids were a major advance, and I'm pleased to say that today, in excess of 90% of women delivering between 23 and 34 weeks gestation get antenatal corticosteroids. Now, it's not the magic bullet, and in the lower middle and income countries where gestational age is not accurately assessed, there's actually been an increase in mortality. This is a comment from Jack Sinclair on the introduction of surfactant. Now, it's interesting because John Clemens synthesized surfactant. Mary Ellen Avery discovered that there was a deficiency of surfactant in babies with respiratory distress syndrome. And Clemens worked with Burroughs Wellcome to synthesize his surfactant and showed that it was clinically useful. And it was really good that in the United States, there was no access to surfactant unless you were participating in a trial until it was proven that surfactant was effective. Now, what's also of interest is that Abbott started making surfactant and in contrast to Clemens, who was synthesizing it, Abbott were getting surfactant from the lungs of cows. Now, fortunately, they chose New Zealand cows for their surfactant production because at the time, the English cows had mad cow disease, and we might have seen another disaster. This is a pre and post surfactant. We could see the whiteout on your left clears substantially, very rapidly, and surfactant reduced mortality by at least 15%. So if we looked at the NICU over a period of 25 to 30 years, erythroblastosis was eliminated with RhoGAM. Group B septicemia was taken care of with penicillin. Better management of the mother, diet, and careful monitoring of her glucose, reduced birth defects and hypoglycemia in infants of diabetic mothers. Respiratory stress syndrome and primary pulmonary hypertension, we now had some treatments. We had antenatal steroids, we had surfactant, we had CPAP, and the development of ventilators. Malformations were diagnosed much earlier with antenatal ultrasound, and over time for pulmonary hypertension, we got nitric oxide and ECMO, extracorporeal membrane oxygenation. The next few slides are really just a list of the major advances. So from a cardiopulmonary standpoint, antenatal corticosteroids, CPAP, mechanical ventilation, and surfactant we've dealt with to some extent. Prostaglandins to keep the ductus open, they were developed by a South African team, Michael Heyman, the son of Seymour Heyman, and Abe Rudolph were the first to do that. And then the use of caffeine has been very effective starting early on. It not only prevents apnea of prematurity, but it assists in getting babies off ventilators. And if you look at the group who get caffeine at 3 to 5 years, you find that their neuromotor development is much improved as well. So babies need their coffee as well. Crimes prevention, the golden era of neonatology, preventing blindness from ophthalmia with the use of antibiotic ointments, hemorrhagic disease eliminated by vitamin K, and retardation. Neonatal screening was put into place, and each year we find that we're expanding the number of disorders that we're actually screening for. And then the simple back to sleep with SIDS. Hepatitis B is another major advance, giving the vaccine to all newborn babies. And it's a tragedy around the world that people are still resistant to vaccination. We've talked about folic acid, and hearing screening has identified deafness early on. So essentially, if I do a look at what were the major problems when I was in training and what are today, asphyxia neonatorum, we now have hypothermia is a very viable therapy. RDS is something that we can handle. We've talked about that. Jaundice has been taken care of, particularly with phototherapy. And birth defects are now a major problem. And one of the big advances, and we're seeing it in the unit, is where you have a mystery, very, very sick baby, and the use of whole gene sequencing, which can now be done in a 36-hour time frame, allows diagnosis of disorders that in the past took weeks and months to diagnose. So, and prematurity, we're seeing improved survival done. Equipment played a major role. X-ray, for example, this was the screening using M-mode screening of the fetus, as opposed to this happy, full-faced fetus. Now, I'm afraid I've gone over time. I hope that you have a sense of the glory years of neonatology and also some of the disasters. And I look forward to watching the advances over the next decade. Thank you very much for your attention.
Hi, Prof. Thank you so much for such an informative talk. Are we taking questions now? You can either raise your hand or post questions in the Q&A and we'll read them. I don't see any questions as yet. Can I start with one? So you mentioned in your talk that we still don't have an optimal oxygen environment, even in 2023. Regarding the patient with BVD, what oxygen saturation should we target?
Well, we have come to the conclusion at the moment that we're trying to keep them between 91 and 94% is the target. But it's not easy to obtain that target and maintain that target, particularly in the kids with bronchopulmonary dysplasia. And over time, this number may change. But using the various modes that we have, including measuring brain oxygenation, at the moment, 91 to 94, 95% is where we're targeting.
Okay, thank you. Are there any other questions from the participants? Okay, there's a question from one attendee. Please may you unmute yourself and hi, Prof Fanaroff. Please may you unmute yourself and state where you're from, and then you can proceed to ask your question. You may proceed, Prof Fanaroff.
Good evening, Prof. Can you hear me?
Yes.
Yes. Thank you for so much for this talk, starting back from where we come from. I mean, where you started, that we're very lucky that we had people like you who were able to open the path for these babies in terms of improving their survival. Thanks for all your work. I've got two questions regarding the interventions. The first one, the lack of effect for antenatal steroids to some babies in the low and middle income countries. What are the factors other than not getting the right gestational age so that we use them appropriately? The second one is about the tussle of induced hypothermia in low and middle income countries from a study that came from India versus what you see in the US in terms of the impact. So what are these differences related to?
You know, those are two very important questions that I'm not sure we have the answer to. The first one, the steroids, it was thought that infection is what was responsible for the increased mortality, although it was never clearly demonstrated that there were more infections in those babies that received the steroids. And similarly, in the hypothermia trial in the LMIC countries, there was more mortality in the hypothermia group. And it's not clear why that was so, because in the developed countries, hypothermia has consistently been effective for moderate and severe asphyxia. So I think we're still trying to work out those questions and come up with the right answers. In fact, hypothermia has been determined as the standard of care. And if you don't offer it and there's a bad outcome, you can guarantee that there's going to be a medical legal action against you. But I'm hoping that there's more data that's going to emerge with the use of erythropoietin. The EPO trial did not show a benefit, but it was done with hypothermia. And it may be that the EPO can't do more than the hypothermia, but by itself, it would be as effective as hypothermia. And that's one of the trials that I'm sure they're going to be doing soon.
Professor Vilapi, do you have a follow-up question? Is that the legacy here?
Yeah, no, sorry, it's another question. One of our major problems, again, I've mentioned the first one, the respiratory distress syndrome and prematurity. The other one is asphyxia related. The third one is infections. They are a major killer in our facilities. And I think in the US, you don't see them as we do. What intervention from your experience that you think has got the major impact in terms of reducing neonatal infections, especially the healthcare associated infections? I mean, what is it that you are doing perfectly that side, or at least most of it is done correctly than us?
I think that this is where you need to establish quality improvement teams and look at the quality improvement literature on infection. And you'll see that line care, when you put a line in, that you're doing an operation, that you're wearing gown and glove and mask, and you're very careful with the antiseptic. So your line insertion is careful. And then the maintenance of the line is critical. But it's a team. You need everybody on your team trained and to be aware of all the components that increase the risk of the baby being infected. The other thing that I would say is that you've got to emphasize human milk. Mothers have to be providing milk for their babies. Human milk makes a huge difference. We've seen a marked decline in necrotizing enterocolitis since human milk is the standard of care in the unit.
Thank you, Prof. There's two comments in the Q&A. There's one from Dorothy Becker. She said, a great career, Ev, and 3 exclamation marks. For younger people, can you describe the very effective ward incubator at Barra in the early 60s?
We had no incubator, but we created an environment which was similar to an incubator. So the babies were all wrapped in cotton wool, and they were swaddled, and the room temperature was such that the staff were uncomfortable. So the key things there were the feeding of pasteurized, pooled human milk, and the keeping the babies warm and keeping their mothers close by. And the incubator was a disaster when they put the sickest baby in the incubator, the baby wasn't going to survive. The incubator wasn't going to make that difference then. I'm glad to hear Dr. Nakwa said that you have 70 incubators now and that you take care of 180 patients. But it's the little things that make a big difference. And Dorothy, it's so nice to hear from you.
And then, Prof, we have a comment from Dr. Chia saying, thanks, Prof, and to the organizers for the wealth of evidence and background information provided. One is learning a lot from this evidence, pointing to origins of developments over the years. So a vote of appreciation, Prof. And then another question from Professor Harun Saluji. Prof. Saluji.
Unmute.
Thanks for that walk down the history of neonatal care, Professor Fanaroff. My question is a hypothetical one. What advice would you give a budding neonatologist, a young physician in 2023, trying to make the choice of whether to emigrate to America or stay and make a difference in South Africa? You made the choice in 1960 for whatever reasons. What advice would you give that young physician in 2023?
That's a very, very difficult question, and it's a political hot potato, okay? I would give that person the following advice. Be a good listener, work hard, follow your dream. And the opportunities, everybody has opportunities. The question is whether you recognize you have the opportunity and you take the opportunity. But there's still a lot to be discovered. The field is very exciting. And as I said, or may have thought I said earlier, there wasn't a day in my career where I said, oh my gosh, I got to go to work today. I really enjoyed work. I enjoyed my colleagues, and be a good listener. Be a good listener. And I was once asked in the early 70s to write down, and it's a book that's actually published by Reggie Tsang and Bill O. What does it take to be a great neonatologist? And I said that you need to have the patience of a career diplomat. You need the skin of an elephant. You need a sense of humor. And above all, you must balance your work and play. You must not miss out on family events and family things because of your work, but you must work hard. And don't put off for tomorrow what you can do today. We had an interesting episode once where one of my colleagues was asking one of the fellows to do something. And he was giving all sorts of excuses as to why he couldn't do it. And while he was doing that, the other fellow went, did it, and came back. The fellow who did it and came back is somebody whose name is probably familiar to you. His name is Dr. Waldemar Carlo, who is the head of neonatology at the University of Alabama, and has been very, very successful. The other guy landed in private practice and didn't do anything.
Thanks, Prof. I'll hand over to Prof. Ashkuvadia now.
Good evening, Professor Fanaroff. Thank you very much. On behalf of the Department of Pediatrics, I really would like to thank you for this really wonderful tour and, going through the glory days and disasters of neonatology. I've learned so much in such a short space of time, and you've packed so much into this wonderful talk. And for me, it's a particular pleasure to have been able to listen to you and see you, and hopefully we can still host you in the next day or two that you're here, because your name has been in our department for as long as I've known as a registrar. I'm currently the academic head, but we have, you probably know, an Avroy Fanaroff prize that we give to the best registrar in the year. It's an annual prize. And so to finally see you and hear from you is a particular pleasure. But I'm sure I'm speaking on behalf of all of us in the department that have been here this evening to hear this talk, that we've really been treated to quite a wonderful talk. I note that you had spent your early days in training at the then Joburg Gen and also at the Krisani Baragwanath Hospital. But also you spent some time at the then Transvaal Memorial Hospital. And just for you and the others to note that this year, 2023, we're celebrating our centenary. So if you would like, I would be very happy to take you around there and do a tour. I'm part of the board there. But also if you would like to tour Krisani Bara, the neonatal unit, or at Joburg Gen, I will make time available, and all my colleagues will make time. I think it would be really wonderful to show you around.
And I congratulate you on the 100th birthday of TMH. Is it still called TMH?
No, it's called CMI now, the Children's Memorial Institute.
Okay.
It's not a hospital at all, but it's a center that has about 30 odd organizations that look after children with special needs.
Okay, thank you. Appreciate your comments. And it's been my pleasure to be here.
Okay, thank you very much. And thanks to everyone on the audience. Thanks, Firdaus, also for being the host. Thanks, everybody. And we look forward to seeing you again sometime, Prof Fanaroff.
Okay.